Good evening. This is Steve Pisano from San Antonio, Texas, PRMA, coming to you live with Courtney, who's going to help me tonight. And we're going to talk about breast reconstruction, mostly about the DIEP flap or DIEP flap, which in our practice is the preferred method of breast reconstruction. In fact, we crossed a very significant milestone. Yesterday, we did our 7,000th DIEP flap yesterday, individual DIEP flap, and at PRMA, we're very proud of that. That is an amazing accomplishment, but behind that are many brave women and men who have trusted their care to us. So the DIEP flap is the procedure we use most often. And to review, that's the technique where we take tissue from the lower abdomen or the tummy down low, and we transplant that to the chest area to do the breast reconstruction. We like that method of reconstruction because it gives us soft, warm, and we're going to talk about this in just a little bit, oftentimes sensate tissue. That is, it has some sensation and duplicates the look and feel of the native breast really better than anything else we feel that we can offer. There are other places on the body we can get tissue to do the reconstruction. The inner thigh, the outer thigh now, the back, and they all have their advantages and disadvantages. But again, for the most part, we say the workhorse method of reconstruction in the practice is the DIEP flap. This is an operation that is a transplant. We're taking the tissue off the body, it's skin and mostly fat, not muscle. We're working through the sit-up muscle or the rectus abdominis muscle, and we're tracing the blood vessels through there, and we're taking skin and fat only. But it's a transplant, so we move the tissue off the body. Instead of from one person to another, it goes from one part of the body to another, and we're hooking up a set of blood vessels, usually from the inner chest, to bring circulation to that tissue in its new location. And then once that's done, in 4 to 6 months, we might come back and do a revision procedure to finalize the shape and size, achieve symmetry with the other breast if the other breast was not done as a reconstruction. One of the things that has gotten a lot of attention recently is sensation after mastectomy. This is a huge topic because for many years we've understood that when a patient has a mastectomy, they're going to lose most of the sensation, if not all, to the breast and chest wall area. In our world, when we work with a general surgeon or an oncologic surgeon here in San Antonio, we try as best we can to get them to make the thickness of the native breast skin that's left after the mastectomy as thick as it can be, as good as it can be, because the thicker that layer is, the better the sensation in general. Even doing breast reconstruction with a tissue transplant like the DIEP flap, sensation is still an issue. And this is something that really contributes to postoperative satisfaction and quality of life. When we do say the DIEP flap again, we have the opportunity to hook up a sensory nerve that comes with the tissue. When we're dissecting, or oftentimes we'll use the word harvesting the DIEP flap from the tummy, we can pick up 1 or 2 sensory nerves that would ordinarily give sensation to the lower abdomen, and we trace those out for a distance. And then after we've reestablished circulation, we'll hook that sensory nerve that goes to the flap up to a sensory nerve in the inner chest. Typically, it's a sensory nerve that has been cut in the course of doing the mastectomy. So we reroute it into the flap. Then that transplanted tissue, that DIEP flap, will regain sensation over a period of time. And very frequently, patients can perceive hot and cold, deep touch, maybe in the best of circumstances, light touch. Now, we'll take this one step further, talking about sensation after mastectomy and breast reconstruction, and that is nipple-sparing mastectomy. So in my lifetime as a reconstructive surgeon, we have gone from removing not only the nipple and areola, but a great deal of breast skin. Fast forward now to, I would say, the majority of mastectomies done in our area of San Antonio with the general surgeons we work with, a nipple-sparing technique. So this has been a game changer. Not only for sensation, but of course also for appearance. And these two things together add up to quality of life after a mastectomy and reconstruction. When at all possible, we prefer to do a nipple-sparing mastectomy. We would urge our general surgeons or our oncologic surgeons to do the mastectomy in that fashion if the patient is a candidate to have that done. And as a quick footnote, generally you want a smaller tumor. A couple of years ago we would say 2 centimeters, but now we've pushed the limit, even 4 to 5 centimeter tumors, and a tumor that is far enough away from the nipple areolar area, say 4 centimeters from the nipple proper, maybe 2 to 2.5 centimeters from the edge of the areola, depending upon how big the areola is. So if those criteria are met, for the most part, we can do a nipple-sparing mastectomy. Things that would make a person not a candidate would be what we say a multifocal tumor, a tumor that's in multiple places or in and around the nipple areola or under the nipple areola, inflammatory breast cancer, things of that nature. We would be a little reluctant to do it for fear of leaving breast tissue behind that could result in a recurrent cancer later, or difficulty clearing the margin from the initial breast cancer that you're dealing with.
Okay, so we'll start with some questions that have come in.
Yeah.
How long after surgery, DIEP flap surgery, doing a sensory nerve reconstruction, does the feeling return? Is it instant? Does it come back a year later?
That's a great question and a frequently asked question. It's not instant. And I would say it takes a year to a year and a half to regain the sensation that you're going to get from that given reconstruction, especially if a sensory nerve has been hooked together. And the reason for that is you put the nerve together and it grows from the good nerve in the inner chest area through the nerve of the flap and all the way out to the perimeter of the flap. And that takes time. Again, measured really in the first few years, year and a half. So it's something that requires some patience, but it'll get better over time.
Okay, and how does that compare with someone who didn't have the sensory nerve reconstruction? So let's say someone who had an implant.
Yes. And
their sensation regained comparatively in a year. What's the difference in sensation, if any?
Well, I would say a patient who does not have a nerve repair for whatever reason, let's say it's a flap where we could not do a nerve repair or an implant reconstruction, the sensation's not likely to be as good because you've got no pathway for nerve growth and extension out into the skin that was left over the breast after the mastectomy has been done. Now, when we do a DIEP flap, even if we don't hook up a nerve, some patients will regain or gain sensation to the flap itself. Somehow the nerves kind of endings find their way into the flap. We do see that. With an implant, not likely to happen because you don't have living tissue that those cut sensory nerves can grow into because you've got that inanimate object there, the implant itself. So for this reason, since we're speaking of tissue versus implant, in our practice here at PRMA, this is one of the reasons why we favor a tissue reconstruction because, again, sensation, the softness, and the overall look. The other thing that has to do with sensation that's important is the patient's perception of, does the reconstructed breast feel like a part of that person? Does it feel like a part of you? And in my long experience of doing tissue reconstruction, I can put the hammer down and say, absolutely, a tissue reconstruction leads to a result where the patient feels like, yes, this is part of me. Now, the nerve putting together process absolutely helps with that. But even when we can't put that nerve together, you'll get a little bit of sensory ingrowth and patients feel like that tissue breast reconstruction is a part of them. Implant patients maybe, but in my experience more often say, well, it feels kind of stuck on. It doesn't feel quite like a part of me.
Okay. We've got a great question here. Can the sensory reconstruction be done at the time of a preventative mastectomy with immediate DIEP?
Yeah, absolutely. We do that all the time. Here again, some women who elect to have a preventative mastectomy or prophylactic mastectomy, let's say they have one of the genetic syndromes, BRCA1, BRCA2, to name two of the most common. A patient who elects to have a preventative mastectomy has the option of either retaining the nipple and areola complex or not. And some women decide, well, I don't want to save the nipple and the areola because I'm concerned that there's a little button of breast tissue underneath the nipple, and that could give rise to a cancer later, even though statistically and by the studies we have to date show that that's not the case. But nevertheless, psychologically, some patients they just don't like the idea of doing it. But when a preventative mastectomy is done, absolutely, in the course of, again, say doing a DIEP flap, we can hook up a sensory nerve. Here's the thing. There are studies to suggest that the overall sensation to the skin envelope is better when you make the flap sensate, meaning you hook up the nerve, because those nerve endings grow into the flap, through the flap, into the overlying skin.
Okay. What is the likelihood of regaining sensation after having delayed reconstruction versus immediate?
Another very good question. It's a complicated question. When a delayed reconstruction is done, in general, there's much more of the abdominal skin that provides the surface to the reconstructed breast, because usually in a delayed reconstruction, a good bit of the native breast skin has been removed. Therefore, most of the presenting surface, if you will, of that reconstructed breast has come from the abdomen. So I would say in our practice, we really try to make our delayed reconstruction flaps sensate flaps. So those are the patients, if we really are wondering, can we safely hook up the nerve so that it doesn't interfere with the lay of the land of the blood vessels and tracing out the nerves and taking that extra time, we would really make an effort to do that with a delayed reconstruction. So the difference between an immediate reconstruction and a delayed then is there's less native breast and chest wall skin. And so our delayed patients, the flap itself might regain some sensation, but the skin around it may still be a little bit numb because a good bit of that native breast skin has been removed.
Okay. We have a gal here who is 7 months post-mastectomy and has been fitted with expanders.
Yes.
And just finished radiation. She's saying the lack of feeling is also spread to her armpit and the back of her arm, and
Yes.
it's very frustrating.
Yeah.
She wants to know, what are the chances for a deep reconstruction to help with the sensation in the chest and the arm back area?
Another great question and a complicated question. So to begin with, patients lose sensation in the chest, especially outer chest and inner arm, because during the lymph node part of the operation that the general surgeon does, or the oncologic surgeon, sensory nerves that come to the breast actually come from the outer chest and travel through the underarm area. And these nerves can be injured or cut during the course of a lymph node dissection. These are the intercostal brachial nerves. You know, costal is chest, brachial is arm. So these nerves kind of run from the chest to the inner arm. When we work with our general surgeons, we try to have them save those nerves where possible. And in this day and age of sentinel lymph node biopsies, having replaced the traditional large-scale lymph node dissection, there's less numbness than we used to see. But geographic differences are present in the way mastectomies are done. So we still have patients who get a lot of numbness in the outer chest and arm. When we do a deep flap, again, we can make that sensate and make this front part of the chest have better sensation. Typically, we're not going in the underarm area to try to find nerves to hook up to restore sensation to the upper arm. It's probably theoretically possible, but by the time you get through that scar tissue and you're looking at it, it's going to be hard to find those cut nerve ends because they're maybe a millimeter and a half in diameter, about the size of a piece of spaghetti. They're hard to find in that post-operative period. So we haven't tried to restore sensation to the inner arm, but in a delayed reconstruction situation, again, we would try to make that flap sensate to give sensation to the front of the chest area, absolutely.
If someone has had immediate deep flap reconstruction a little over a year and a half ago, and has gone through revisions, multiple fat graftings, some feeling has restored, but they also have occasional throbbing or spasm-like pains. Is this normal?
Absolutely. That's a great question, and I thank the person who asked that question, because as sensation is returning to the breast, along with the good, you can get, the not so good, and you can get shooting pains. Sometimes that come almost sort of randomly. Sometimes it's a dull ache, but more frequently kind of a shooting pain. The good thing is, for the vast majority of women, and in my experience, this is temporary. Okay. Having said that, that means in some patients it's not temporary, it's more long-term, and we do see that as well. That's called post-mastectomy syndrome. Post-mastectomy syndrome arises in the setting of a mastectomy because all of the sensory nerves to the breast have been cut, and then as they grow back, they kind of don't have any place to go. And we especially see this in a delayed reconstruction, again, before we have living tissue put on the chest wall. So most commonly, I see this post-mastectomy syndrome in the delayed reconstruction patient. This can be a real burden because it's shooting pains, it can be throbbing, again, sometimes a dull ache. In some women, it's not very common, but it can be really incapacitating. Here again, as a footnote, we will often treat that with a medication called gabapentin. The trade name is Neurontin. Low doses typically are very effective in my experience, and the medication in the low dose that we use tends not to have significant side effects. Again, post-mastectomy syndrome can benefit from a tissue reconstruction. It's not the cure-all in every patient, but in my experience, in the majority, it can be very helpful.
If someone has had a DIEP flap here or elsewhere, is there a way for them to know if sensory reconstruction was part of their reconstruction, especially in a delayed situation?
Yeah, I would say to the patient, ask your doctor. If you have a doctor who did a DIEP flap, they're going to know whether they hooked up a sensory nerve or not. They're going to know about that. They're going to know about the benefit of doing it, and they're going to know in their own experience, in their own practice, if it's something that they routinely do. In our practice, we get 7 doctors in this practice. I don't know everybody in the world who does this operation, but we know the serious operators in the world of tissue reconstruction. So the surgeons who do a lot of this, it's either going to be a part of their routine or not. They're going to try to do it wherever possible, or they're going to tell you, I don't take the time to do it. But I would think that if you've had a DIEP flap, your surgeon's going to know.
Perfect. And then what if the patient isn't a candidate for DIEP flap? Are there other options, flap options, reconstruction options that can help with restore sensory nerve reconstruction?
Yeah. I would say the thigh-based flaps, so from the inner thigh, there are a variety of flaps. It's really the same basic flap, but a variation on a theme of the skin island. So the original version was the tug flap. The T stands for transverse. It's kind of an upper almond-shaped skin pattern. It can also be a variation where it's vertical, and then it's called the VUG flap. These are flaps that are based off of a thigh muscle. It's kind of an expendable muscle in the lay person. It might be a muscle that an athlete would require, but it's called the gracilis muscle. And there's a nerve. It's both a motor nerve and it has sensory fibers to it. It's very easy to trace. It's a large nerve, and we will usually hook that nerve up in the course of doing an inner thigh flap. From the outer thigh, there's a flap called the ALT flap, anterolateral thigh flap. And it's actually become a flap that I like as an alternative to the inner thigh-based flaps because the donor defect is better in terms of contour. Yes, there's a scar in the upper outer thigh. It's vertical. In our demographic area, patients don't seem to mind it. And that can also be a sensate flap. You can find a sensory nerve that's coming from the outer thigh area and hook that up.
This is a good question. If a patient's had a lumpectomy,
yes,
and wants to later on do the mastectomy and DIEP flap, at PRMA, what do we do? Do we work with a mastectomy surgeon to then help with regaining sensation and for there to be a better chance of reconnecting those nerves?
A patient who has undergone a lumpectomy sort of has 2 pathways for how the mastectomy is done. If it's somebody in our geographic area who's done the lumpectomy, we would offer the patient or that surgeon, if the patient is wanting to stay with that surgeon, the opportunity to do the completion mastectomy. A patient from an outlying area or another state, usually we do the mastectomy ourselves, and then we would discuss with you whether or not you would want a nipple sparing mastectomy or not.
Okay. If a patient has had a failed DIEP flap, what
yes.
options are still left for tissue reconstruction and then also regaining sensation?
That's a great question. In the case of a failed DIEP flap, in the course of doing a physical examination on the patient, I or somebody in our group, we would look at where the best alternative donor site is. And the donor sites would again be, just to kind of review in no particular order, inner thigh, I'm pointing to my inner thigh, outer thigh, kind of the upper buttock area. It's really upper buttock and almost kind of the flank. And that's a flap that's called the gluteal flap or GAP, G-A-P flap. There's an upper and lower gap, kind of upper buttock and lower buttock, so S gap and I gap for superior and inferior. So inner thigh, outer thigh, buttock area, and then I would say lastly the latissimus flap. So there's 1, 2, 3, 4, 5 options I would say. So there's plenty of options, and just whatever physically looks like it has the most soft tissue to give us, I would say is the best, would be the best choice.
Okay. Oh goodness. Okay. If a deep flap reconstruction has already occurred with no sensory nerve reconstruction, can a revision be performed in an attempt to reconnect any nerve?
Yeah, that's a great question. I've never done that. I'm not aware that that's been attempted. I will say that that question makes me think of this. When we harvest the deep flap, we mark the sensory nerve with a magic marker. It's always purple. I don't know why patient markers are always purple, but all the different companies that make them, they're purple. Anyway, we mark it. We mark the nerve in the chest that we're going to hook it up to. Sometimes we can't put them together at that time because we're concerned about the circulation. We're trying to get the blood vessels to sit in a certain way. We've got other things to contend with. I guess it's theoretically possible to go back and find the nerves, maybe put in a nerve graft to try to jump the gap that's sitting because you didn't put the nerves together. Maybe someday we'll give it a try. So it's not something we've tried in our practice yet, but who knows?
Yeah. And this is a good question, just going back to if there's a failed DIEP, what options are left? If someone has had the very rare failed
yes,
flap,
that is a rare occurrence.
yeah.
It's a rare occurrence in PRMA.
Yeah, rare occurrence at PRMA, but it is a chance. What is the success of an alternative flap taking and being successful if they've already had one failed flap?
I think it's a two-part answer. The first part is, why did the first flap, the deep flap, not work? Was there a technical problem putting the blood vessels together? Does the patient have a clotting disorder? And we do lots and lots of deep flaps every year in this practice, and in the course of a given year, we'll uncover, I would say, 5 to 10 patients that have clotting disorders, because we'll do clotting studies before our surgery, and we'll pick out patients who have, I would say, subclinical. You wouldn't know it unless you were having a big operation. So the first question is, why did the deep flap fail? If it's a technical thing, a clot formed a day or two after surgery, that doesn't mean you can't have another attempt at a tissue transplant reconstruction. In our practice, we do this all the time. We get patients who've had failed flaps from somewhere else, and then we do an alternative flap like we outlined a few minutes ago, a thigh flap or a gap flap or something like that. So it doesn't mean you can't have a reconstruction. We would just do our homework with you, find out what happened as best we can, look at the op report from the other surgeon, and then, forge ahead, and deal with it appropriately. If it's a clotting thing, maybe you need more in the way of anticoagulant. If it was just a technical thing, it clotted, it seemed like something to do with the way the blood vessels were put together, we would move ahead and try a different flap. And certainly that can be done. We do that all the time in this practice.
Does radiation affect the outcome or result of nerve regeneration because of compromised blood flow from radiation?
Oh, another great question. Lots of great, wow. Yeah, I think the short answer is going to be yes, because radiation affects the native breast and chest wall skin, and it's probably going to make sensory nerve ingrowth less than an envelope of skin that has not had radiation. So I think the short answer is yes, radiation is probably not going to help us too much there. The longer part of that answer has to do with what I was talking about a little earlier, and that is, we could still do a nerve hookup to the flap, and then that most projecting part of the reconstructed breast could develop some sensation and sort of offset maybe some of that radiation-induced numbness.
Is it our standard practice here at PRMA for us to automatically do the nerve reconstruction when doing a DIEP flap?
Yes.
And I'm assuming that anatomy has a big part of...
Yeah. The standard way of doing it is to hook up the nerve. If we don't, again, it means that there was, an intercurrent issue. The sensory nerves that we're trying, and I'll give you, this happened in my case yesterday. The patient had multiple abdominal surgeries. One of them was an emergent surgery, an exploratory laparotomy. That means something was going on. The general surgeon had to get in there quickly. There was a ton of scar tissue, and where those sensory nerves came into the flap, there was just a lot of scar. The nerves were very delicate. We use the word friable. Friable means they don't hold together too well. There just weren't any good quality sensory nerves to hook up, even though I was trying to dissect them and find them. We just couldn't do it. So there's an example of, yes, we want to do it, but it just wasn't going to be meaningful to try to do it.
And this is because we have discussed a lot about DIEP flap tonight, and we did kind of discuss if there was a failed DIEP. Someone that does want to know what is considered a failed flap. They're having their surgery in 2 weeks. And just kind of, will you explain just briefly, since we talked about it?
Yeah. In the world of doing a tissue reconstruction, two things can happen. One, there can be a partial flap loss. This can range from a little small area of what we call fat necrosis, a little firm. It's typically kind of a spherical area, the size of a marble. That would be on the low or benign kind of end of flap loss, just a little small area, and sometimes in the course of doing the revision surgery, we would remove that area because they can be kind of uncomfortable or tender. Ranging from that to, a segment of the flap, a quarter of the flap, a third of the flap. And what that means is that section of the flap just didn't have good blood supply, having to do with the anatomy of how the blood vessels come into the flap and how many we as the reconstructive surgeon included with the flap. Sometimes there's one vessel supplying the blood flow, sometimes there's more than one. The second thing is a complete flap loss, and that would happen if there's a blockage of blood flow going into the flap through the artery, which brings blood in, or blood is getting in, but the vein, the vessel taking the blood out, gets clotted. So blood's getting in, but it can't get out. So neither scenario is good. If blood can't get in, that's no good. If it can't get out, that's no good. And either one of those scenarios could lead to a situation where the flap has to be removed completely. So those are kind of the spectrum. And I would hasten to add, though, PRMA, our practice, the flap loss rate overall is extraordinarily low. In fact, I'm going to go out on a limb. Here's my limb. I'm way over here. The success rate in our practice is pretty much 100%, except a flap may not work on occasion. Here are the numbers. Last year we did 602 individual DIEP flaps to be exact. We had one flap loss. Some years we don't lose any. We'll do between 575 and 600, and we don't lose any. So it's an extremely rare occurrence in our practice. The reason for that is, hitchhiking off part of my discussion a few minutes ago, putting these blood vessels together is a technical exercise. If there's an issue with the circulation, it's usually a technical exercise. It's plumbing. Transplant surgery is plumbing. A kidney transplant is a glorified plumbing operation. This operation we're doing is a plumbing operation. Yes, they're shaping, but the gist of it is putting blood vessels together. But we have aggregate experience in this practice. We have corporate knowledge in this practice, 7,000 DIEP flaps. So on the technical side, we have a lot of experience, and so that sort of a thing is very, very rare.
If someone's already had reconstruction, especially that they're unhappy with, like implants, for example, are they still candidates for DIEP flap? And if so, is that something that insurance would cover?
Yes and yes. If you've had an implant reconstruction, you haven't burned any bridges. You have the various tissue options still on the table. And if you haven't had something that would negate a DIEP flap, lots and lots of abdominal surgery, or you're very, very thin or something like that, there's no reason why you couldn't have a DIEP flap or some other tissue method of reconstruction. The second part of that question Courtney asked me is, will insurance cover it? Typically they do, because most of the implant patients who come to us are coming to us for a reason, and that reason is usually discomfort. The problem with an implant reconstruction long term is discomfort. Visibility of the implant, tightness of the skin around the implant, those sorts of things. So usually those are patients that are going to be a candidate, because that's a reconstruction failure, that's an implant failure.
Okay, and then can you perform the sensory nerve reconstruction on implant patients?
No, because there's no living tissue to hook the chest wall nerve up to. So the breast tissue's been taken out from under the native breast skin. There's a pocket there. The expander or the implant goes into that pocket, and that's the operation.
And then can you talk briefly about nipple sensation and nipple response after sensory reconstruction? Does it act like the nipple that Mother Nature provided?
That's a great question. Couple points on that. Again, nipple sparing mastectomy has been a game changer. It depends how thick the surgeon has left the skin envelope over the breast. Thicker is better. In terms of the appearance of the nipple, the projection of the nipple. In our hands, if we do the mastectomy, we'll leave that layer pretty thick. The nipple can be responsive to a degree. It'll have some sensation. It may not be the full, just going to say it, erotic sensation that you would have had before having the mastectomy, but you'll have some sensation there. So a big element is how the mastectomy was done, who did it, how thick that layer of tissue was left, how thick could the surgeon leave it, because it varies from patient to patient. In some patients, the breast tissue comes pretty much right up under the skin. In some, there's a layer of subcutaneous fatty tissue. Subcutaneous is a fancy way of saying the little layer of fat under the skin that's between the breast tissue itself and the skin. And that can dictate how thick that layer is. So it varies, but yes, there can be a little responsiveness, definitely some sensation. Now, in some patients, if that layer was really thin, there not be much sensation at all.
And then, this is a good question. For the sensory nerve reconstruction, do you cut or sacrifice some nerves in the chest area to be able to reconnect the flap nerve? Or how do you do that? And if so, is there any sensation lost to the upper chest by doing this?
That's a very sophisticated question. The answer to the first part of that question is yes. In a sense, you're sacrificing a nerve. Typically, it's the third intercostal sensory nerve of the chest, okay? But here's the thing. that nerve where we hook it up is intact, but where it comes through the chest wall, the pec muscle, and into the breast, typically it's been cut somewhere at that level. So I like to use the word borrowing that nerve. We're redirecting it into the healthy nerve of the healthy flap. Sometimes, and this is especially the case if we in our practice have done the mastectomy and we know that that layer is really thick, we haven't skeletonized that skin envelope too much. In that instance, we might elect not to borrow that nerve. We might leave that nerve alone because we figure it's still in continuity. It's still going where it's supposed to go. So in our hands, we might leave that alone. But the person who asked the question has a good point. In a sense, you're kind of rerouting or redirecting that nerve that ordinarily went to the inner breast. The second part, I don't mean to interrupt you, Courtney. I haven't found that it makes that overlying skin more numb. However, I don't think that that's the case.
How much of a factor is BMI for a successful outcome with deep and sensory nerve reconstruction? Are there risks associated with a higher BMI?
A wonderful question. Well, the issue of deep flap safety and BMI is an important question. A good bit of what we know about that topic actually was done by research from our practice. Dr. Ochoa, Oscar Ochoa in our practice, was the lead author of a paper on the relationship between BMI, body mass index, that's a formula of your height and weight, the relationship of BMI to deep flap safety, particularly in the donor site area. So the key number when you're looking at body mass index is 40. A body mass index of above 40 leads to a much higher complication rate across the board, chest and abdomen, particularly in the abdominal wall, the donor area. Wound healing problems, infection, separation of the wound dehiscence, seroma formation, things like that. So in general in our practice, we have a cutoff of not doing a deep flap of BMI above 40. There can be some exceptions, depends how the person carries their weight, but in general, we try to stick to that. We try to have patients who have a BMI over 40 lose weight and get at or below 40. Now, once you're at or below 40, it's what we've talked about. We'll do a sensory deep flap if we can do it. That would be our standard. And really, there's little relationship to BMI and being able to hook up the nerve at that point. Being able to hook up the nerve would have more to do with what I talked about in an example a while ago. Previous abdominal surgery, scarring, the quality of the nerves. Can we get a long enough nerve? Is it big enough to warrant hooking it up? That sort of thing.
And then can you just briefly touch on how non-local patients could come to PRMA if they were interested, like are out of state and are far away from Texas?
A great question. A great many of our patients do come from outside San Antonio, and Texas is about 1,000 miles wide and 1,000 miles tall, so even other parts of Texas is a big undertaking. And we realize that and we respect that. So we have Courtney and Brittany, our patient liaisons, and help coordinate our out-of-city and out-of-state patients. So we work carefully with patients to help them get hotel accommodations and plan how long they're going to stay in the San Antonio area after their surgery. And we take it one step further. We will in advance look at patients' photographs, get their records, do a consult in advance by Skype, kind of like what we're doing now, or by telephone. We do that for free. That's a daily thing in this practice now. And for patients who are a pretty straightforward candidate, we would set up what we call a 2-day turnaround. A 2-day turnaround is patient comes in maybe on a Thursday or Friday, and they'll have surgery on a Monday to try to streamline the whole process. And we have again, Brittany and Courtney, we have staff, we're accustomed to doing this, we've been doing this for a long time, and can make it as seamless as possible. Absolutely.
And then we have one final question before we wrap up. If a DIEP flap has already occurred and a patient wants to add further volume, can a different flap be added?
Yes. However, before that, we would, in the course of doing the revision or the second stage, most likely add volume by doing what's called fat grafting or autologous meaning from the patient, autologous fat grafting. And that's what I did today. Today was a series of revision procedures, second stage procedures, and I did 3 of them, and all 3 of them got fat grafting. So in the course of doing fat grafting, in the final case I did, it just sticks in my mind, I did 130 cc's, milliliters of fat grafting. Well, if you think about 130 cc's, that's the size of a small implant. So our first option, probably best option, would be fat grafting. That typically gets the patient to where they need to be. In some circumstances, yeah, we'll go back and add another flap, sometimes a latissimus flap adjacent to the DIEP flap, on top of the DIEP flap. Why would we do that? Maybe the patient had a radiation after they had their DIEP flap, and the DIEP flap decreased in volume, or the patient had a area of fat necrosis that was so big that we needed another flap. But those are rare circumstances in our practice, I would say. But yes, can be done.
And can the fat grafting be done years later?
Yes, absolutely. Yeah. As I think about the patients I operated today, one had her reconstruction, not at our practice, her initial reconstruction, but it was done like in 2013, 2017, so 4 years ago. And a good bit of what I did today, again, was fat grafting. So, yeah, the remoteness of it is not an issue.
And is it possible to do a DIEP flap procedure with sensory nerve reconstruction on a patient who had reconstruction with implants 6+ years ago?
Yes, because again, when we are doing our work in the inner chest to find our blood vessels to hook up to, that's where we pick up that sensory nerve. And again, by then it's been cut, but we'll reroute it into the flap. So absolutely, yeah, standard procedure. Well, I guess that's all the time we have for this session. I so appreciate any of you viewers who've stayed with us. It's our privilege at PRMA to take care of the brave women and men who have breast cancer. We in this practice, and I personally have devoted pretty much our entire adult lives to taking care of patients with cancer. It's humbling, it's a privilege. We'll do our best to look after you should you come to PRMA. Feel free to contact us through social media, contact Courtney, Twitter, Facebook, and we'll be happy to answer any questions you may have about tonight's topics or anything else you may want to know. Thank you.